One place I wanted to start would be your fascination with physical therapy. Where did your fascination begin with the whole idea of it? And maybe now, what's something that you found that's, in your own words, something that you found that is interesting with physical therapy?
Yeah, I mean, I've had a lot of injuries in the past. When I was younger, I was athletic, and I had a knee surgery when I was 15. I had ankle fractures. I had a lot of issues physically.
Hmm.
And my wife's a speech therapist. I tried teaching for a year as a high school teacher, but she thought that entering into one of the therapies would be a good fit for me. I like science. I always love science. I love helping people. And again, I've been through the same thing. I've been through injuries myself. So I thought I could help others due to my own experiences. Yeah.
And is the field of physical therapy what you thought it was?
Um, yes and no. I mean, so far, there are really some positives that I like about the job.
Hmm.
Meeting people and connecting with people. It's a little more redundant than I thought it was going to be. And it's not as, I don't know, maybe it's because of what I'm in and the type of therapy. I'm in home care. So it's not as challenging as I thought it would be.
Hmm.
But on the other hand, there are some really good aspects to the job, like meeting people, making connections. It's For me, it's great flexibility. It's one of those careers that I don't have to be in an office all day. I can drive from one place to another. So there's definitely benefits. So there's pros and cons to being a physical therapist for sure.
Did you always know you were going to do home health, or did you start out an outpatient? What was your mind with that?
I actually started out in pediatrics,
Mm.
and my wife's aunt is a physical therapist, and my wife is a speech therapist, like I mentioned, and they were working in a school. And I thought I would give it a shot being a PT working with my wife's aunt. But I did that for 2 years, but I realized that A, I wasn't as passionate about that field or that area. And B, I'm actually pretty big. I'm 6'5", and it was really hard for me to work with like little kids, kids with autism, kids with Down syndrome. I had to get on the mat a lot, and it was just really difficult on me physically. And I
Mm.
realized that it was time to move forward. So I went into home care. I actually had a clinical instructor that I kept in touch with. And after the school that I was working at actually shut down, and then I decided I wanted to try something different, I called him up and I said, "What are you doing?" He said, "Home health." I said, "Are they looking for anybody?" And he said, "Yeah." And that was it. We made a connection, and I've been with that same company for the last 10 years.
That's great.
Yeah.
I go into people's homes as well, and I do outpatient. I can imagine when you first walk in the door, is the first question, "How tall are you?"
Yeah, exactly. Or as I speak about in my webinars, do you play basketball? That's
Oh
always
yeah.
a question.
Is your answer to your question disappointing?
No, I did play basketball.
Oh, okay, gotcha.
But
And
it's one of those biases that exist that if you're tall, you must have played basketball. So
that's, yeah, I mean, it's usually, and that's why I asked that question, because I feel like every time he's like, "How tall are you?" And I'm 6 foot, but even then sometimes I still get the question like, "How tall are you?" I'm just like, I'm here to see you. Okay. Let's get over this whole thing. And you started talking about how you change careers. The field of physical therapy is kind of monotonous in a way. And so I guess, when did you start thinking about changing careers, or at least diving into a different aspect of physical therapy, where your interests were? Because it seems like your heart, or at least th- your heart maybe had been in physical therapy, but maybe not in its entirety. And so I guess, how did it lead to change paths or do something different?
yeah, great question. For me, like I always had a passion for psychology in addition to being a PT. And one of the things that I was always interested in is bedside manner patient satisfaction. That's really one of my webinars. I give a bunch of webinars, but I recognize that for myself, I'm not an extrovert. I'm more of an introvert. But I realized that I was still connecting with my patients in a very meaningful way. And I figured that there must be a system that exists that anybody can use in order to connect with your patients. So I started thinking about the psychology of patient care and how we can understand a system based on psychology, social psychology, on how best to connect with patients. And I saw with my other therapists, my colleagues, and I realized that my success as a physical therapist was really tied to my ability to motivate my patients, connect with them. And I saw that there were some therapists that were better and some therapists that were worse. But I knew that I was getting referrals, constant referrals, and I was always busy because of that ability. So my thought process was, how can I teach others how to do this? Because I'm not a natural necessarily, because I'm more of an introvert. I'm more quiet. I'm not a natural talker. However, I figured that there must be a system, and it would be interesting to try to teach others how to utilize that system.
Mm.
So yeah, so that's why I changed. And then it was just more of my wife pushing me and saying that you need to go back to school, because really I had all the knowledge. I've always been interested in psychology. I didn't want to be a clinical therapist. I was never interested in that. I was more interested in understanding people's thought process, how people think, and utilizing that knowledge to the advantage of the person. So I never really wanted to be a clinical therapist, but my wife, so I had all this knowledge, but my wife was saying you should go back to school, get more knowledge, and also get the credentials and the credibility that you could really teach this information to others. So that's
Mm.
why I ended up changing and going to a master's program.
Now, you use the word system, and I think that word is interesting because I feel like sometimes as clinicians, we don't understand how to put what we do into words. And so, developing a system, or at least developing a core set of perhaps personality traits into a system, how did you get that idea? Was it, what is it, did you cultivate like, okay, these are 4 things that I've noticed that are really helpful? Or was it something that you gradually started to learn more and more about as you went through psychology?
So I say it's a combination of the two. One
Okay.
thing is I was noticing what was working for me, what things were working, what things weren't working. But also about a couple of years ago, I started getting into social psychology, which is based on the books of Daniel Kahneman, who's a Nobel Prize winner, and in economics, which is interesting. I think he's the only psychologist to ever win a Nobel Prize.
Hmm.
But basically, his idea was that in economics, we typically think of people as rational, and economists build models based on the rationality of people. And his idea as a psychologist was to show that people have systematic irrationality, and they're called biases. And he goes through it in his book, Thinking Fast and Slow, what all these biases are. So it's basically like Dale Carnegie stuff. I don't know if you're familiar with Dale Carnegie books,
Hmm.
but it's really more sophisticated, and it shows you based on scientific experiments, psychological experiments. And he himself had developed many of these ideas working with the Israeli army and basically doing psychological studies with their Air Force pilots to see, who would be best fit to fly for the Israeli army. And, so he used a lot of these experiments to develop his ideas in psychology, and they're based on the concepts of called heuristics and biases. And there's a lot of other writers that are similar, like Dan Ariely is a great writer. There's another book that I read, or that I've read, called Influence. So there's a lot of books on this topic on how to understand systematic biases, what most humans have, and just understanding and being more aware of what those biases are. And I try to teach it as a way of connecting with your patients. So that's where I come in, and I kind of take that knowledge and that information that I've gained from the books that I've read and I'm very passionate about, and I try to take that and teach others how to use it for the benefit of the patients.
Yeah, I think I want to get into the topic of bias, but I also I want to kind of stem off on that word connection, because when we think of connecting with our patient, we're talking about bedside manner, and bedside manner has always been something that, as clinicians and as doctors, it's something that's always been, and even for patients, it's been something that's super important to not only the patient but also to the provider to get better at. And so, I guess, what are some of the biases that we bring into bedside manner? Because I know for me, sometimes, some patients connect with me right away. And sometimes you have to put in a little bit more work to at least understand what's going on with this patient, or like who they are, so you can connect with them. And so when we go to a patient, or when we see a patient for the first time, what are some biases that we bring to the table in regards to bedside manner that maybe we're not aware of?
That's a great question. Again, so some of the biases, well, I try to think about the biases from the framework of the patient. So most patients have what's called the similar to me effect, which is a common bias that is somewhat unfortunate because it could lead to prejudice. But really what it means is that you're more attracted to somebody who's similar to you.
Hmm.
And that exists within humanity. And there's different reasons why that could be. Some psychologists say, like Freudian psychologists believe that you love yourself the most. So you're naturally attracted to somebody who looks like you, who talks like you, who acts like you. Or it could be from an evolutionary standpoint, the fact that your family members are those who you trust the most to survive. And they look like you. So that's why you trust people who look like you, who sound like you. So when you go into a patient's house, it's a lot easier sometimes to connect with somebody who looks like you, who sounds like you, comes from the same background. But if you don't have that, then you have to really find a connection through a similar experience. So like I'm 6'5", and if I go into a patient's house who's 4'10", and I'm American and I was born in America and they're from a different country, I really have to find experiences that we share in common. So I like to talk about parenting because I have kids. I have 3 kids. I like to, because if I know that they have kids, I work with a lot of geriatric patients, so many of them have children and grandchildren. So I try to hit up that topic. And there's also another reason psychologically, which is that I want them to know or feel a certain security in me. And there's a bias that people have that if you're married, as opposed to like being single, which is not necessarily true, that you're responsible, that you have a family, that you take care of them. So the idea is that I try to connect through that experience, that shared experience, but there's other ways to connect too. Like I give another example in my webinars, I have patients that speak Polish or Spanish, and I speak English, but I have picked up a couple words here and there. So on my first visit with a patient who I know is of Polish descent, I might throw out a word in Polish just to like throw it out there, and they appreciate it. They think it's nice and it's funny, and it's like showing that I'm making an effort to connect with them through their language, or Spanish as well. So in that way, I'm able to find that spark between us, that connection, and through that it develops a relationship, a patient caregiver relationship, and that could be really, and that's why I think it's most important to be on your game at evaluation. You really have to have your A game in bedside manner, because first impressions are really key. That's another bias that we have, that we develop our impressions of others based on their appearance and when we first meet them, how they act towards us. So really at your first visit, if you show that you want to connect with them through talking about experiences like parenting, like vacations is another good one, throw out a word in a different language. These are ways that you can really build relationships with patients early on.
Yeah, and it really plays to the term of like first impressions are everything, right? Like it's first impressions are super important. And why is it important to connect with our patients? Like, it's very easy to just walk in and be like, all right, I'm here to treat you. Let's get to part one here. Instead, we go down this at least we should try to go down this idea of connecting with the patient. Why is it important to connect with the patient?
Yeah, so I think that there's 2 reasons from my own experience. One is that you get greater follow through. So if the patient feels more connected to you, they're more likely to put in all their energy when you're there, and also their home exercise programs, which I also have a webinar on how to use motivational tools to improve adherence to home exercise programs. But if they like you and they trust you, so they're more likely to follow through on their exercises. And the other, I think, is the placebo effect, which is that if a patient likes you and they feel like they're getting better and you're personable, so they'll use that information and that knowledge, they'll convince themselves psychologically that they're actually better, and it improves their outcomes. And there's a lot of research to support the placebo effect, and you see that with a lot of different procedures in physical therapy that aren't necessarily proven or evidence-based. Like for example, I'm not an anti-cupper, but with cupping there's not so much evidence towards it, but a lot of people like it. It makes them feel good and they actually feel better. So the placebo effect is working there, I think, somewhat. So the same could be said by bedside manner and patient satisfaction, that if you make your patients feel like they're doing better and you make them feel comfortable and show them that they're progressing, they'll actually feel that way and it'll improve their outcomes. So those are the 2 reasons I believe.
Yeah, and there's an interesting study. I don't know if you saw the same one. I don't know if it was the one in your webinar where it was knee replacements and they did a placebo sham study.
Yeah.
And with cupping, it's kind of like it's not massage, but it's similar in that it's a superficial thing, right?
Right.
And not that there's not a physical change, but it's something that's very superficial, not huge, and like not a significant change. And so with the placebo effect, I think people always think of like, well, nothing really, like the sugar pill idea, right?
Right.
But for instance, this knee replacement study was that they had 2 groups, and maybe you can speak to it better than I can, and one got the knee replacement and one didn't. And was it after 12
Yeah.
weeks they had similar outcomes and pain level?
Yeah.
Was that it?
Yeah, I think it was a meniscectomy. I don't think it was a full knee replacement.
Oh, okay.
But basically these doctors just cut open the knee, did nothing inside in the sham group, and they did just as well as the surgery group. And some people still felt better, even though they just cut their knees open with a knife. So if I told you, I'm going to take this scalpel and cut your knee open, and you'll feel better, you'd say that's nuts. But if a doctor's wearing, the white coat and they put you under and they do the same thing, all of a sudden you feel better. So it's the placebo effect. There is always that element that if you think you're getting better, if you think the doctor is competent if you think your physical therapist is competent and you trust them, then you actually will improve your outcomes.
Which is interesting because it's like, should we focus on improving our treatment style, or should we focus on becoming a better communicator, right? Because if the placebo effect is something that's very important and obviously won't work for everybody, but if these, how do we prove that the treatment is actually working versus the patient just likes you?
Right, that's a great question. I mean, well, just to speak to that, in terms of that, what you just mentioned, I find with my colleagues that there is a bias in terms of like bedside manner. A lot of people think that it's just innate and they feel like their clinical skills are way more important than their bedside manner skills.
Mm.
So one of my goals in teaching my webinars is to demonstrate from my own experience. It's very hard for me to prove it. I just know from my own experience that bedside manner is equally as important as clinical skills. And B, everybody can improve, because if I usually ask the audience, do you think you can improve on your clinical skills? And everyone pretty much says, of course. But then when you ask people, do you think you can improve on your bedside manner skills? Very few people say, of course, because they take it as like an innate criticism. If you're not good at bedside manner, then you must not be a good person, or you're not a personable person. Nobody wants to feel that way. So my goal is to try to show that it's a skill set. It's just like clinical skills. It's very difficult to prove, though, that whether it's the clinical or the actual bedside manner aspect. And I think it's a combination of the two. So it's not really the question of how much importance you place on one or the other is, I think, subjective somewhat. But in my experience, it's more 50-50 than it is, 80% clinical. So that's what I've experienced.
Yeah. And one thing that I found interesting, I think there's a word that, a lot of institutions probably use, and I learned in PT school, was like biopsychosocial model, and making sure
Yeah.
you're using multiple areas to treat the patient. And so I think that is important. However, I think I'm seeing a couple people treat in a way like, oh, this is a biopsychosocial patient, or this is just like a need, like this is somebody who needs like extra attention, and like this person's just a minisectomy, or like it's almost like labeling an individual based off of their issue. And I guess, how do you stay objective in saying like, I'm going to be biopsychosocial with everybody? Like, some people are going to need talking to, some people really just need exercising to get back to where they were. And how do we avoid this like labeling that I keep seeing, where you're like, oh, this person's like got chronic pain for the past 9 years, and they're over objectifying their pain? How do you kind of
I
stay?
mean, I think the best way to do that is to use like a screening tool of sorts. I do, in one of the webinars I give on home exercise programs, I saw an article where they used a screening tool to figure out which patients required more motivation, persuasion. It was based on self-efficacy, whether a person has high self-efficacy or low. So they would give out a screening tool in order to determine that. I don't remember the name of the screening tool, but I think at some point PTs should use kind of a screening tool to determine what the personality type of the patient is, how much belief do they have in themselves in terms of achieving their goals. It doesn't have to be sophisticated. It doesn't have to be like a 30-minute test. It could just be a quick, 2-minute, 3-minute questionnaire where you can develop an idea, a more objective idea about the person's issues and whether or not they're more physical in nature or they're more psychological in nature.
Mm. Is there a correlation between patients who are motivated or have like a certain personality trait and completing their home exercise program?
Yeah, definitely. There's people who have high self-efficacy, so they're not fearful. They tend to be more confident people. They're more internally motivated in general. Yeah, those people follow. There is definitely studies that show that they follow their home exercise programs to a much higher degree than others who have low self-efficacy. So that's where you as a PT really have to rely on these motivational skills and techniques, which is something that I teach for those patients who really need it. For other patients who are like, I have a patient right now, I just saw them today, knee replacement patient. He's really young. He's like in his late 40s, which is pretty young for a knee replacement. He used to play soccer, and I saw him for a couple visits, but after the first visit, I gave him exercises. The guy is amazing. I mean, he's been doing them every single day. I didn't have to motivate him. I didn't really use any like major motivational tools, and he's doing incredible. Like, I don't even have to see him anymore. I told him like one more visit, I'm going to discharge him. So he's doing incredible. I have other patients where they just want to give up. Like, I had a patient yesterday, an older man with a stroke, and I really had to motivate him. I had to try to find, the best way to motivate somebody in a nutshell is to find out what they care about most and use that to motivate. So there are two types of motivators in psychology. There's extrinsic and intrinsic. So extrinsic would be that you're motivated to win a prize, to win a trophy. But intrinsic is if you love something for itself, like if you love to play golf, you love to bicycle, anything that you love for itself, you love playing with your kids. So these things, the intrinsic motivators are more powerful than extrinsic motivators. So you have to know your patients and you have to know basically what they're motivated by. And then you can use that to really push your patients towards their goals. And in doing so, they'll be more adherent to their exercises, home exercise programs.
And for people who may be listening that are, maybe not, they're not clinicians, maybe they're people who are just trying to get back into exercise. Is that kind of the same model you should approach of like, what intrinsically do you find that's important to you? Because I know sometimes with exercise, people always try to trick themselves as like, okay, if I do this workout, then I can have like I don't know, I can have dessert later, or, it seems like intrinsic motivators are something that keeps people more motivated to do something for longer. And do you think it's the same with people who are just trying to exercise, stay fit and stay healthy?
Yeah, definitely. I mean, if you love an activity, so you should incorporate that activity into your workout as much as possible. And I've seen a lot of therapists do that. Like a lot of therapists use VR now. And let's say you have a patient who loves golf. So then you can really integrate that if you want to motivate the patient to get back on the course. So you can use programs and you can use apps and you can actually use golf simulators in order to get the patient back to where they are. But really what you're doing is you're taking an understanding of what they're intrinsically motivated by and incorporating it into the exercise. So I would say that, yeah, for sure, if you're intrinsically motivated to lose weight, to exercise, it's going to be way more powerful than if you're just motivated by a prize.
Yeah. And I think one thing that can happen too is as we start developing relationships with our patients, sometimes the patients can develop a relationship with you essentially, and not in the sense of platonic, but things that are they really like you. Like sometimes you're the only person that they talk to all the time, and you mentioned this in your webinar as well as, and it's this thought experiment between clinical judgment and patient satisfaction. And so I see this with my home patients too, that sometimes patients want to just be seen because they need someone to talk to. And so when do you make the discernible difference between somebody who needs care versus somebody who really needs to kind of like, all right, listen, like we need to, find the motivation in you and, use some of these external things that you want to get back to so you can do it on your own, because ultimately you want them to do it on their own because that's what you were there for. But sometimes it's not always the case. So I guess, how do you combat that?
Yeah, I mean, it's really hard for me to give an answer like, a one size fit all answer, because I do have that issue, like just like you. I mean, I find that a lot of patients, they think that therapy is like unlimited. So, and they feel like, oh, I could just go back to my doctor, he'll give me a prescription, I'll get more therapy. And then I have to explain to the patient that it's really, the goal is like what you just said, which is to get them to do it on their own. And we're not really there to maintain their level unless you're under maintenance therapy, which is a whole different class in Medicare. But other than that, I mean, it's really difficult. I mean, it's an ethical dilemma also, because if you're not really providing them with the skill and it's more just personal connections, so then you have to ultimately make the hard choice, and you have to tell them and explain to them that this is the way the system works, and that also you want to say, like, I wish I could stay. I always say it to my patients, I wish I could stay forever. So you want to show them that you like spending time with them. I wish I could just give you therapy for the rest of your life, but unfortunately the system doesn't work that way. So you don't want to, I think that's the best way to approach it. Don't make it like a personal, I don't want to see you anymore. Make them feel like you really do want to see them, but the system is set up in a way whereby they really have to learn to do it themselves.
Yeah. And one way I've been trying to do that as well is by getting them involved as much as possible with their treatment. And what I mean by that is asking them questions like, how have you feel like you've made progress? Where do you feel like you're at? And so when they start in some patients, I've seen that once they start realizing, oh, I think I'm better than I thought I was, and I made more progress than I think I have. It's much easier to have that conversation. Are there other tools that you've found success with, perhaps, to be like, because I've had the same talk where it's like, listen, I wish I could see it forever, but honestly, like, we need to, you need to be independent. So are there other tools or maybe ways to get patients to understand what we're trying to do here?
Well, Well, great. I mean, something else that you could do is to try to talk to the caregiver or the spouse also. I mean, you want to get them on board with the mission. So you really have to utilize your relationship, not just with the patient, but with their caregiver. And you have to get the caregiver on the same page as you early on, so that when you're ready to discharge the patient, you can use the caregiver, you and them together can kind of tag team and convince the patient that it's time to move on. So I think that's the other tool that I would use, which is really connecting with the caregiver and making sure that you're listening to them and sharing your plan of care early on, and talk about it early on. You know, this is normal, and say in terms of how many weeks I'm going to see you, and tell them what your plan is, that my plan is that I'm not going to see you forever, early on. That way they know that it's not never ending. So you really have to set that as a precedent early on.
Yeah, and thinking about this in general, and just the psychology terms, I think for people who are clinicians, or maybe you're like a personal trainer or somebody who doesn't see like clinical care, setting a foundation and setting an idea in the beginning of like, this is what I want to achieve, perhaps may allow you to find the motivation, or at least have a direction to go. Because let's just say, for instance, you set the goal of like, I want to be more fit. Okay, well, what does that mean? And I think perhaps being more direct and saying, I want to do 20 push-ups in 6 months, and being more
Right.
direct, and writing something down that will at least give you some sort of direction and where to go, and you can track that progress along the way, so that way you can stay motivated and keep moving, and you can use that as a ploy, or at least a tool to try and exercise more, at least get more fit, because sometimes you need to fool yourself sometimes. And so
Yeah.
again, for the non-clinicians out there, I think this is really important, that people need to understand that you need to be able to have a direction, and your direction cannot be vague. And same thing, what I'm thinking about now is, expectations. And with clinical care, what I try to do, especially when I'm treating a patient, is saying, okay, we're going to be doing this, we're going to do that, and then we're going to do the other thing. How important is it to tell the patient what you're about to do, and the course of care that you want to go through? Because sometimes you just walk in the room, you ask them how you're doing, and then you just start your evaluation. But I guess, how important is it to explain how you're going to do it, what you're going to do, and then like what this all means?
I mean, I think it's essential. I mean, I know with my patients, as you mentioned, every time I go in for an evaluation, I try to be, as I try to explain to them what's going on with them. I try to be as educational as possible. I think that if they feel like they understand what's going on a deeper level, they'll feel like their care is more collaborative, and they'll be more motivated, because they'll feel like it's not just you taking care of them, but they're actually involved, and it's also about validation for them, and them feeling like they're heard. So if you treat them like a colleague almost, and you're direct with them, and you explain to them what they have, what their situation is, what your plan of care is, then and you demonstrate respect towards them, then they'll reciprocate with respect towards you. So I find, yeah, it's definitely a really important bedside manner quality to educate your patients, instruct them as to what your plan of care is. And a very, like you mentioned, the goals have to be very concrete. They can't just be vague as well.
Yeah, and getting them involved and having them at least answer the question, like, what do you want to do? Like, do you want to walk more? Do you want to go upstairs? Do you want to return to playing soccer? Do you want to, making those goals concrete, and getting, and like having them say it, they can actually understand it. And do you believe that it's important to go over anatomically what's going on with the patient? Because sometimes if I start talking about anatomy or things that are going on in their body, sometimes they're just like, listen, I don't care, man. Like, just tell me, tell me what's going on, and then we'll just get to it. Do you find there's a mixed bag of people who want to know?
Yeah,
Um,
some patients love it. They're like, oh, that's what they did in the surgery, or they didn't. It's like their surgeon never explained to them what exactly they were doing, because the surgeon had no interest. So then when I explain it to them, they love it, because now they understand somewhat. And I try to, obviously you can't use the same language you would use with a colleague, so you have to use simpler medical terminology with your patients. But I have some patients that love it, and then there's patients that don't want to know what's going on. Like there's a funny, my son, my oldest son, when he was younger, I mean, he's 10 right now, but when he was younger, he used to love watching like YouTube videos about medical procedures, which is an interesting passion. But my mother, yeah, my mother was having hip surgery. She had a hip replacement, and my son wanted to know what was going on. So I found this like animated video. It wasn't a real video, so it wouldn't, scare him or anything. It was an animated video, exactly how they did the surgery. So my son was on the phone with my mom, and he was trying to explain to her, this is what the surgeon's going to do. They're going to cut open your hip. My mom was like, don't tell me. I don't want to know. I don't know what's going on. So some patients, they have no interest in being explained to exactly what's going on in their body and what surgery happened, but others, they love it. So it depends on the person, you know?
Yeah, and I think you might have a future surgeon on your hands. You might have might have to start saving for medical school for him. And
Definitely.
when you bring up kids, and so are these biases that we've been talking about something that we're born with? Is, I mean, you kind of very vaguely touched upon like innate versus like almost kind of like these are biases that we learn. Um, is is everything kind of stemming from like when we were born, or is it kind of something that we learn along the way? Because some people are, you know, obviously people are different, and so are these biases adopted, or are they something that are inherently learned?
So some biases are learned and some biases are adopted, but there's different theories as to why. I mean, if you take like a Freudian approach, so he'll go back to your development, your early development, and how you relate to yourself and those stages of development according to Freud. Evolutionary psychologists believe that a lot of these biases were developed in humanity as a whole because it promotes survival. Because, for example, and one of the examples I give in my webinar is that if you're, let's say you came across a dangerous looking dog, like a pit bull. So many people have a bias that pit bulls are dangerous and that pit bulls by definition will bite you. And from a survival standpoint, you're better off overestimating the danger of the animal than underestimating it. So most people will make a quick decision based on what they've seen on TV and what they've read about pit bulls, and they'll start running away or they'll be scared. And that's something that's built into humanity in order to help us survive, that we make these decisions. So the point of a bias is that it's not correct. Not every pit bull is dangerous. And it might be the pit bull that you came across is really a friendly pit bull. But the bias is there because oftentimes we need to make quick decisions and we can't be as analytical as we want to be. And there's actually a benefit from the standpoint of evolving and surviving. So that is the basic premise of evolutionary psychologists on how biases developed in humanity. It was all a means of assisting us in our survival. So we make these, like trusting somebody who looks like you. So that's something that could either, like I mentioned before, that could be based on Freudian psychology, or it could be based on survival. That in general, your family members look like you, so you trust them more than other people because they're most likely people who are going to protect you. So for our own survival, we rely on these biases, but then we forget about the fact that they're biases and that they're not really true. Like just because somebody looks like you doesn't mean that they're similar to you or that they're protective of you. We just assume that because as children, we needed to rely on people for survival purposes. So those are some of the reasons that biases exist. So there are like common biases that I go through, but according to Kahneman and all these other social psychologists, these biases are in general exist in the population as a whole, and he proves it through various studies, psychology studies.
And
like another bias, for example, I'll just give you another example.
sure.
So there's a bias called contrast errors. So what it is Dan Ariely is an amazing writer. He's also a psychologist. He teaches at Duke, but he has a double PhD. He used to be a professor at MIT. So he would do all these social psychology experiments. And the best, before we move on, the best book that I recommend that he wrote is called Predictably Irrational. It was a New York Times bestseller, really amazing book. So anyways, one of his studies, he shows that people think in a relativistic manner rather than an objective manner. And he uses an example. So if you go into a bar by yourself and you're looking to meet somebody or get a phone number, are you better off going in by yourself or going with somebody else, like a wingman or a wingwoman? So the answer to the study that he performed, was that you're better off going in with a wingman or a wingwoman. However, you're only better off if they're worse looking than you. So if you're better looking than them, then you're more likely to get numbers rather than going in by yourself. And the reason is because people don't view you in a tunnel. They view you more favorably if you're standing next to somebody who's less attractive than you. Or if you're very tall and you're standing next to somebody very short, you might think that, oh, people are objective. They'll see me as 6 feet regardless, but it's not true. Studies have shown that if you're standing next to somebody short, you look taller than 6 feet, as opposed to if you're standing by yourself. So that would be like a common bias that people have that exists in humanity, that we think we lie to ourselves and think that we're completely objective and that I can view your height regardless of whether. So I usually use an example from the movie Twins, where Arnold Schwarzenegger was standing next to Danny DeVito. So they're like polar opposites, and the movie's all about how they were twins separated at birth. But the point is that if you look at Arnold next to Danny, he looks like way more powerful and Danny looks shorter. But if you look at them on their own, they don't look the same way in our minds. We don't judge them the same way. So that's a common bias that exists in humanity as a whole. It's not limited to like certain ethnicities. Everybody has that to some extent. We compare ourselves. It's hard for us to be objective and look at people in a tunnel. So that would be an example of a bias. And I use that in my bedside manner webinar about how important it is to have a consistent clinician, for example, because your patients are always comparing you to the other clinician. Right. And if the other clinician is better than you, is a lot better than you, you're going to look a lot worse. If they're a lot worse than you, then you're going to look a lot better. You probably want somebody who's somewhat similar to you. And I know that it's hard to find, but let's say you're on vacation and you're in your office. Your office should try to find somebody, and you work for an office, excuse me. Your office should try to find somebody who's similar to you in their approach to patient care. You don't want to get somebody who's like that much better, because then when you come back from vacation, they're like, why do I need you? I want the other person. You don't want to get somebody that's that much worse because it looks bad for your company. So try to find people who are very similar in their approach. And there's always groupings of people in terms of their approach. That's what I found. So that would be an example of how you can use the bias to prevent, to prevent an error, for example, to prevent, to prevent a patient dissatisfied with their care.
So more of the story is find an ugly friend, so that way you can look more attractive.
The joke in the book is that he says, don't tell them that they're less attractive to you, then just take them. Yeah.
The key is that they have to be, if they're funny and then they're unattractive, then it's perfect. It's a perfect, perfect duo.
Exactly.
And you mentioned comparing. One thing that you've also mentioned in your lecture, but one thing I've also seen multiple times in my in my practice with patients is that they always compare and they always ask, how am I doing in comparison to your other patients that you have? And so I guess what is an appropriate answer to that? Because I always, depending on the patient, I'll kind of change my answer. But I guess what's an appropriate way to respond to that? Because you don't want them thinking that like, everyone's doing really bad, but you're doing excellent, because then it's using that bias. But at the same time, you don't want everyone to think you're a bad therapist. So I guess what would be an appropriate response?
Well, you have to tell them, I try to limit it as much as possible. So I always say to the patient, it's not important how others are doing. Everyone's different. And I tell them that, you're doing great right now and you're making the progress that you need to make if they're making the progress. But most of my patients, I said, some people are slower than others. Just explain to them, but try to limit it and say it's not important how others are doing. You're doing fine. You're right on track. That's what I try to do. I don't want to give into it, because if you give into it, then like you said, either you're lying to them, and if you say everyone's terrible but you're doing great, and if you do the opposite, they're not going to like you either. If you say everyone's doing great but you're terrible, so try to just limit that thought process as much as possible. And by just saying it's not important, what's important is that you're doing great, and if you keep doing your exercises, then you'll for sure hit your goals.
We talk about this and we're talking about it in retrospect, but in the moment, how do you stay objective and kind of think in that manner? Because it can be easy just to go with your first gut reaction, because the patient's in front of you, they're looking for an answer. And is it just practice, like continuously practicing those skills? Because I can imagine in those situations, sometimes whatever comes out. And so having those tools, and for you, has it always been something that's been natural where you always fall into the camp of using like psychology to explain things to patients?
It's just I happen to not be like an explosive personality. My nature is that I'm very contemplative, and I think a lot before I speak. I'm not that person, so it's a lot easier for me. There are people that I know who aren't like that, and for those people, probably repetition, like doing the same thing over and over again, like you mentioned. For a person who's more explosive, you just need repetition. You need to keep doing it, just like any other clinical skill. But for other people who are less reactive and more contemplative, then you can think about it more, and you can be more analytical and then kind of implement it. For me, I've never had an issue because I'm not that type of person. Like I don't get angry very easily. When somebody annoys me, I kind of think about it. I don't really have this desire to like react explosively. It's just not my personality. I guess that's a good thing, or I don't know.
I think in most scenarios, it's definitely
most scenarios it's a good thing. Yeah. I do speak about aggressive patients in my webinar, and how the key to dealing with aggressive patients is to see the early stages of aggression and try to address the aggression before it gets out of hand. Because the people who are explosive, it tends to work in stages. It's not just 0 to 60, but usually it's like 0 to 20, then 20 to 40, then 40 to 60. So if you recognize what it's like for a person from 0 to 20, then you can, as opposed to before they get to 60, you can kind of address the aggression early on. And in that way, you can prevent, a lot of explosiveness from happening.
What do you mean by aggressive patients? Are just people who are dissatisfied with their quality
Yeah,
of
just
care?
dissatisfied. We're going to complain. We're going to say, we're just going to call and complain. I mean, thankfully, I haven't had very many patients like that, but there are patients who are explosive. They get angry. Like I didn't get, I find with like durable medical equipment. So you'll order something for the patient. It'll take a while before it gets there. And then they get frustrated, and you want to like address the frustration early on, try to listen to them, validate what they're saying. And in doing so, it prevents the patient from getting out of control and just screaming at you and calling your office and screaming at the managers and stuff like that. So yeah, that's what I mean. Yeah.
I don't think I've ever had a patient scream at me. That's something I haven't thankfully experienced. That I don't know what I would do in that situation. Be like, why are you yelling, dude?
Well, yeah, I mean, I don't think I've had a patient scream at me either, but I have had patients who scream at my office.
Mm.
So they'll call up my office manager, or the manager that I work under, and they'll say, where's my this, where's my bed, where's my hospital bed, where's my wheelchair? And they go nuts. So some patients are like that, and you just have to know how to deal with them.
Yeah, and well, something I also want to talk about is trauma. And one thing that I've been kind of just like dabbling in on the side is just talking about trauma and how we adaptly learn trauma, or at least experience trauma. And one thing that I've learned recently is that when we experience trauma at the age that we experience it. And so trauma comes in many forms, and trauma is very individual. And so, do you find that trauma is something that trauma can be related to injuries? Like, do you think injuries are enough to be caused as like maybe like a little T or like a big T trauma, and that we can maybe classify injuries based off of that? Because I think people need to, classifying that, and there's obviously a lot of psychological barriers that are associated with injury. Do you think it's almost enough to say that these are traumatic events for patients?
Definitely. Yeah. I mean, it depends on the type of injury and how it occurred, but I mean, I know for myself, I had an experience where I was snowboarding once. This is like 5 years ago, and I was sliding down the mountain. It was very icy, so I fell backwards, and I was trying to stop myself on my snowboard, and I wasn't catching anything, and I ended up sliding off the slope, and luckily it wasn't off the mountain. It was in like a ditch in between two slopes, but I was wearing a helmet, of course. But literally, um, afterwards, I didn't break anything, but my glasses were cracked in half, and I had a bloody nose and my eye, and I almost hit a tree. I was about to hit a tree. So thankfully, I wasn't I was fine, and it really scared me. And that type of trauma, even though physically it wasn't so bad, it wasn't so dangerous. I haven't gone skiing since then, or snowboarding since then.
Wow.
My wife refuses to let me go. She was watching the whole thing from the bottom of the mountain. She just saw this big lumberjack looking guy like fall and come off the mountain. She was freaked out. So yeah, certain types of injuries are definitely like more traumatic than other injuries. And it definitely, I also, I think, yeah, I definitely think that psychology plays a part in terms of injury, in a big way, in terms of causing injury. Like you might be stressed out, and you might not be as aware of your emotions or feelings. And when you're let's say playing a sport and you're not fully committed, you're thinking about something else, you're not giving it your all, for example. These are things that create injury. So being aware of your emotions before you play a sport, before you get involved in, I love cycling, and I've fallen on my bicycle like maybe 2 or 3 times. But when you're thinking about something, when you're stressed out, you're not as focused on what you're doing. That's what causes injury, and then it becomes, or could become, a greater source of trauma, for
Yeah.
sure.
And do you think people who have higher emotional intelligence are able to overcome those types of traumatic events or injuries?
Yeah, I definitely think so. For sure. I mean, how you develop that is becoming more self-aware. There's a theory called self-awareness theory, where you can try to write down your strengths and weaknesses and kind of approach yourself as an outsider would. And in that way, you can become more emotionally self-aware and aware of yourself, and where you're coming from, your own perspective. So I definitely think that those people are more protected from trauma. I also think that, I mean, I know there's a big, I don't know if you ever heard of Dr. Sarno, but he's a big developer of the idea of how psychology plays into pain and back pain, for example. And he maintains, or he believes, that repressed anger and stress and anxiety are really a major cause of back pain And he proves it because he shows that if you took a random sampling from the population, took an MRI of their back, you'd find that there's a significant amount of people that have herniated discs, but there's a much lower significance of people who feel symptoms as a result of those herniated discs. So he has a book where he talks about all the different types of injuries that are associated with repressed anger, repressed anxiety. There are very common ones that he says that there's no real anatomic reason why one person should feel a certain way and another person shouldn't if they have the same thing going on. So he really believes that understanding self-awareness is the key to getting rid of pain and removing certain types of pain.
And how does anger and stress and other emotional stressors affect pain? Because it's very easy for me to be like, well, my foot hurts. How does that affect? Why does that affect with why my foot is hurting if I'm stressed out? I guess what are the mechanisms that kind of drive that?
Right. I don't know if there's a clear explanation of what the connection is. It's just that if you do therapy with, that's one of his treatments. His treatment is a therapeutic process where he has them basically become self-aware. And a lot of these people are people who are very, they're in jobs that are very stressful. For example, like a lot of his patients that he talks about, they have certain personality types and they're in these like really high stress jobs. So he specifies that there are certain injuries that are typical of anxiety stress,
Hmm.
especially back pain, but he goes through other injuries as well. And sometimes it's physical and sometimes it's not. So the question is there anything anatomical that you can say is really different about you than other people? If other people have the same thing, but they're not experiencing any symptoms, so then maybe you have to look inward and try to figure out what's going on. But I also think it's always a good idea, no matter what, if you're to like reflect on what's going on in your mind, in your head, because even if your foot hurts and it's not connected, what do you have to lose by trying to think about the stress that you're going through? If anything, you'll just feel better, and maybe your foot won't feel better, but at least you'll feel better emotionally and mentally. So
Yeah,
I think it's always a good idea, if you're capable of it, to reflect on what's going on in your life. Is there anything causing you stress? Are you angry about something that is it repressed? Are you try to become aware of your emotions as much as possible, and I think you'll feel better overall.
yeah, and the way we develop pain is, and we interpret pain is through our brain, right? And so, my favorite example of how we can basically think ourselves into pain is the guy who I think he was on a job site and he like stepped on a nail or he fell off of something and his a nail went through his boot and he went to the ER like in excruciating pain. He's crying. He's like, get it out. And they couldn't get an image because it hurt so bad. And they brought him into surgery and they knocked him out and they took the boot off and the nail was in between his toes. Like it hadn't even gone through his foot. And it's like
Right.
we can create these scenarios in our head of just like how much pain we're in versus actual physical pain. And so I guess we have to remember in a sense that our brain comes from our brain, and that doesn't come from our brain, but it's interpreted in our brain. And so we have to be aware of that if there's some other stresses in your life that could also affect the interpretation of how much pain you're in, whether it's more or less.
Yeah, definitely. I mean, you also see the opposite with a lot of Buddhist monks. I know that they've done these crazy pain experiments where they'll be like on fire and they won't feel anything. So you're capable of increasing your pain tolerance using your mind and using concentration and different methods and techniques. So again, I agree with you. A lot of our sensation of pain is tied to our perception of pain. And if you could overcome and if you could elevate, so then your sensation level will go down and you won't experience pain to the same degree or level.
Yeah, and we've been talking about overall just like connecting with patients, right? That's what we've been wanting to do. Is there a counter argument to that? Like, do we not want to connect with our patients? Because I've always thought of House because I watched all the episodes and seasons with House, where his whole mantra is not to develop a relationship with a patient, to not see them, and he
Yeah.
is like this amazing. Of course, this is just a TV show, but I guess
Right.
is there a counter argument to the idea of connecting more with the patient?
Yeah. I mean, the counter argument is that it could impede your judgment, your clinical judgment, which we spoke about in terms of ethically. Like if you're too connected to your patient, you might not make the right judgment call and you might continue therapy forever. So that's one way. But also, I actually bring this in that webinar on the science of bedside manner patient satisfaction, where I speak about how the arguments against it is that it influences you to make like the opioid epidemic is a byproduct of the fact that doctors they're too they're too involved in patient satisfaction. They're too connected to their patients, and they don't want their patients to be dissatisfied. So, and also some people say it doesn't really measure patient care and the quality of care. So there has to be a balance, like you mentioned. There has to be a balance between the importance of bedside manner patient satisfaction and clinical care. Because if you're too much on the side of patient satisfaction, again, it'll compromise your judgment and your decision making, and you'll end up doing unethical things.
Absolutely. Yeah, absolutely. I mean, I remember there was this doctor, I think there was a book about it, or there's a show called Dr. Death. And he was like this physician or a neurologist who was performing like unnecessary, like back surgeries on all these patients. And he did it for years. And the only reason why he got away with it was because he was hopping from like hospital to hospital. And, no one, eventually no one just like stopped him, because it was just like, well, this isn't our issue, you can deal with them. And so he would go from one place to another. I
Right.
guess like, and how can we maybe keep ourselves more accountable in that regard? And
And the ethics, I mean, in terms of ethics,
yeah.
that I mean, it's a hard question to answer. I mean, you have to it's I think self-awareness is really the key. You have to be aware of what your value system is. The value system of the APTA and the AOTA are really things that we should, as professionals, live by. And if you're aware of those values and you become aware of conflicts with those values, then you'll be able to make the right decisions. But with less self-awareness, then you make decisions, just you make these instinctive decisions, and sometimes they're unethical. So yeah, I think just awareness is the key.
Yeah, and I think awareness is important, but also part of that I think is being empathetic to what the patient is experiencing and what they're going through. And I guess, in your own words, how do you define empathy? Because nowadays I feel like a lot of people throw around that word and they say like I'm trying to be more empathetic, and sometimes they may not exactly understand what the word empathy means. So I guess, how would you define empathy?
Yeah, so empathy is defined as kind of feeling what the other person is feeling. So if a person is sad and they're at a funeral, for example, and you see people crying and you have the desire to cry, so you're kind of identifying with the other person's emotion, feeling what they're feeling. If they look depressed and you are sad because of it, not as an outsider, but you're trying to feel what they're feeling, that's empathy. Or and the opposite, if you're at a wedding, for example, and somebody that you're seeing is really happy and you want to smile and you want to laugh, it's like you're feeling what they're feeling. So that's really empathy. And there's ways to improve it. I mean, that's another aspect of one of my courses, which is how to improve your empathy. And some of the ways we can do that is by reading books about people who've gone through terminal illnesses. There's a book that I recommend in my webinar, because when we see other people and we read about other people's illness, we get greater insight and greater knowledge into what they're feeling. And with greater knowledge into what our patients are feeling, we're more likely to feel what they're feeling, and it makes us better clinicians.
Mm.
So another aspect of empathy also that the research shows is that it can be broken down into two parts. One is identifying other people's emotions properly, and the second is sharing in those emotions. So if you're not good at identifying other people's emotions, like let's say my wife is rolling her eyes at me and I don't get what she's saying to me, I think that she's really happy with something that I've done. So then I'm not going to be empathetic. So and it's not going to be perceived as empathetic by my wife. I'm going to be perceived as, as the opposite, as a terrible husband. So you really have to get good at reading other people's emotions through their body language, through their tone, through their facial gestures. And then once you can do that, then the other aspect of empathy, which is sharing in that feeling, comes into play. And different people have different capacities in terms of feeling empathy. But again, you can improve on it by reading books, by also reflecting on your own experiences of trauma, like we're speaking about. That will make you more empathetic, and also communicating empathy. I speak about how even if you're not feeling empathetic towards the patient, let's say the patient's annoying you, you're not really connected with that patient, but you want to be a good clinician. So you have to communicate in an empathetic way, which is where you ask the patient how they're feeling. You try to explore their emotions a little bit. When you notice that they're feeling down, you can just ask them, just basically active listening, asking them questions. These are ways to convey empathy, even if you're not feeling it inside.
Do you feel that, we're talking about empathy and emotional intelligence, how important, I mean, and they're probably synonymous with one another, but how important do you feel? Because I think people naturally at a baseline, unless you're like a psychopath, you're going to feel empathy, right? You can feel it, but perhaps you don't know the way to communicate or ways to put it into like language. And so do you believe that there's more an issue with practicing empathy, or do you believe there's a bigger issue perhaps in putting thoughts into feelings and perhaps putting feelings into communicating that to the patient?
I think it's more communication. I tend to think that people in general, I'm an optimist, and I'm also I think that people in general are empathetic. They're not psychopaths. Most people are empathetic towards patients, but I think that that's where the disconnect occurs. If you're not conveying it to the patient, then the patient doesn't know that you're empathetic. They don't know that you're trying to feel what they're feeling, and if that's the case, then they're not going to feel connected to you. So I think it's really critical and essential that clinicians learn how to convey empathy. There are situations where you're not going to feel empathetic, and it's normal. Like I said, if a patient's annoying you, or there's a study that says that as we get older, we get more disengaged from our jobs as PTs, and our empathy levels go down, our natural empathy levels go down. But if our natural levels of empathy are going down, we still have an obligation to our patients to act and communicate empathy so that we connect with them. So that's where the skill set of understanding the words and the terms and what you should and shouldn't say are really important.
Did you
Valuable.
ever did you ever have a issue with practicing empathy yourself? Do you feel like you ever had a hard time just like connecting with patients?
Sometimes, yeah. Sometimes there are patients that I kind of think are, I've had patients where I think that they're too sensitive, or in terms of like their pain levels, like they have a low tolerance. And I'll think to myself, come on, it's not that bad, you're overreacting. But I don't want to tell the patient they're overreacting or convey that. So I have to use these skills and these tools of communication in order to show them that I really feel the extent of their pain, even though deep down inside I know, or at least I don't know, that would be wrong of me to say, but I feel like they're over exaggerating their pain. I feel like they're not in as much pain.
Yeah,
So
and I think
that
we've all had that
yeah,
one patient where they're like, how much pain are you? And they're like 10 out of 10.
yeah,
And they're just like
exactly.
completely even
You're like,
keel.
and
You're
then
like,
you're like, should we call the ER and call the ambulance? And they're like, no, no, no.
yeah, do you think there's a way to better convey and ask that question, like how much pain you're in?
Yeah, I mean, I try to say, if you're a 10, I'll say, how much pain are you in? And I'd say a 10 would mean that I would call the ambulance. So then you put it in that, from that framework, and then you can kind of get a better estimate of what their pain level is, I
Mm.
think.
Yeah, I think so too. And I think I usually say if I use the ER one. I used to use if it couldn't be worse if you lit it on fire, but I think that was a little bit too aggressive. So I stopped using that one. But I think we all have different ways of trying to get to the basic answer of like how much pain you're in. And
Right.
are there better clinical tools, I guess, that you use to try to maybe weed out what type of personality a patient is, so that way you can change the way you're treating?
Well, I don't use an objective measurement tool. I mean, I would love to see one developed just for PTs, and that would
Mhm.
be a great research study, and something that I think maybe a school should conduct, which is how a PT should use an objective, or what an objective measurement would be in order to screen patient personalities. I just use my own experience, and my own knowledge of psychology in order to screen my patients. But yeah, I definitely think that there would be a good to having a tool like that.
What were some of the psychological barriers that you dealt with, maybe that you addressed when you first started learning about this stuff? Were there things like in bedside manners where you're like, man, I didn't know I was doing that?
Yeah. Yeah, I had one that I was thinking about the other day. Hold on one second. I'm trying to
Mm.
recall what issue oh, so one of the things that you're not supposed to say from an empathy standpoint is you're never supposed to start a sentence with, well, at least it wasn't this, or at least it wasn't that. So like if a person has broken a leg, you could say, well, it could have been worse.
Mm.
It could have been that cracked your head open and you'd be in a coma. So you're not supposed to say that. But sometimes I fall into a trap where I want to say, like, put this in perspective. It's kind of what we just spoke about when a patient is over exaggerating their pain. Sometimes I just want to say, oh, and for some reason, I think it's a positive to say, you have a lot of other things that are great going on. Let's just put this in perspective. But patients, they don't want to hear that. They want you to validate what they're feeling. So that would be something that I have to like correct, because I have a natural tendency, because it's a bias of myself, that I tend to look at things with, I guess, greater, broader perspective. And I
Mm.
get in trouble with my wife at the same way, where I'll say, oh, let's just put this in perspective. So I kind of do that. However, I know that people don't necessarily want to hear that. So that's not really, that's not a good bedside manner technique. You want to more validate what they're feeling.
Yeah, be like, well, listen, kids are starving in other countries. You know, you can get over your
Exactly.
pain and be like, I didn't need this in my life. All right, I just wanted you to
Yeah,
help my ankle out.
exactly. So you want to avoid that. Yes, for sure.
um, you've created these courses and they're fantastic. You know, I haven't gone through all of them, but I went through one of them. And you know, what was it like building these courses? I guess what were some of the things that you're like, this needs to be the highlight of what these courses are built for?
First of all, I love building courses. It's just I was a teacher before. I went to PT school, and I've taught informally for the last 15 years, different topics and different subjects, not to PTs, but in a different area. But I love teaching. So, and I love developing ideas and putting them in PowerPoint slides and creating and organizing my thoughts. So, like for me, that's amazing. And I love research. So it works out perfectly for me. And I want to show PTs and OTs and healthcare clinicians how the value of psychology and how I know like a lot of PTs that I speak to and OTs, they have no idea they don't know anything about psychology. They don't know how it could be utilized, what techniques exist. So my goal as a teacher and having this expertise in psychology is to share that insight. And I have different topics that I speak about. So you watched I think the Science of Bedside Manner and Patient Satisfaction, but I also have a course on leadership and how you can use an objective psychological measurement to determine personality types. You can't use that as a PT for your patients because it takes like I think 40 minutes to complete. But I go through it and how you can use that knowledge and that information to develop leadership skills in PT and OT and to communicate with other PTs and other colleagues, and also works with patients. I have one on burnout, which is a significant issue in the clinical world, and I teach how different psychology strategies can help effectively reduce burnout. I have one on ethics that I talk about and the psychology of ethics. And there's a great book called The Righteous Mind, which discusses the basis of ethics from a psychological perspective. And I take that and I use that information to go through the code of ethics in the APT of the APTA and AOTA, and how there's like a lot of gray areas and how we determine what's right and what's wrong. So I just wanted to bring my passion for psychology. In the future, I hope to develop courses on pain and psychology. I'm working on one right now. So yeah, I just want to share what I find interesting and really helpful. And I've noticed from my colleagues that there's a lack of awareness of its significance in rehab. So I just want to share that with my audience.
Absolutely. I mean, there's so much to benefit from, and I think it's the space is getting bigger and bigger, and it's getting more and more important for patients to or in clinicians to understand the role of how psychology works, because if you understand that, it definitely improves our treatments and uh, our abilities to help patients. And I guess, did doing these courses and building these courses help with perhaps you feeling burnt out with the job that you're doing right now?
A little, I mean, well, I would say that when I started developing these courses, I realized that my passion really lies in teaching.
Hmm.
So, and I love it. So it kind of, I mean, I'm still working as a physical therapist, but I'm actually in the process of transitioning full time to being a teacher instructor. But yeah, I mean, I think it's really important to find within PT, because that's one of the benefits. And I forgot to mention this early on. One of the benefits of PT is that there's a lot of different settings, a lot of different opportunities to explore areas you can work with and different patient types. So you really have to find where your passion lies. And I realized once I started developing courses that this is what I love to do and I'm really passionate about. So yeah, I'm focusing more on that now.
And how do we be careful with not becoming a psychologist? Because, you know, at the end of the day, we're all going to be, you know, people are going to be PTs, we're going to be OTs, we're going to be physicians, and you know, we can't always be the best PT and also the best psychologist. And I guess, at what point do you perhaps like refer out to a psychologist, or at least how do you bring up the conversation to say maybe this would be something of benefit to you?
So I think that if you see like a consistency of a person's mood, like if you notice that your patient's always depressed when you're seeing them, so then I start recommending like seeing a psychiatrist. It depends on how transient their emotions are. If you notice, again, and it also you can determine it based on how depressed they are as well. There's different levels of depression. If a person is really unmotivated, they really don't want to do anything at all for you, or you notice that they're really not putting any effort in, then that's time to refer to a psychiatrist or psychologist. But you really, so those are, I think, the level of depression, sadness, anger, anxiety, and also, how permanent it is, how consistent it is. Those are different ways that I determine when it's time to refer out.
Yeah, I
But
agree.
I'm a big believer in, I mean, I'm a big believer in therapy in general. So I think, I think everybody would benefit from going to a therapist, a psychologist, or psychiatrist, just to, again, become more aware. And so it's not like, for me, it's not a stigma or anything. I feel like, I would recommend it to any patient. If I thought that they would benefit from it, I would say, yeah, going to a therapist is great.
Yeah.
Definitely learn about yourself.
And I think, like we said, we all have our own biases and, non-judgment. And I think it's become more and more um, normal for people to be like, yeah, I talk to a psychologist once a month, or I go see a psychiatrist once a month. And I think that's been really helpful, especially within the past couple of years of just life. I think it's been really important. Did you see more people being more stressed or perhaps more depressed over the past year with the pandemic?
Yeah, definitely. I mean, I noticed that, and I noticed for myself, which I speak about in the burnout course, um, a lot of my burnout was from the pandemic. I just felt so nervous about getting my patients sick throughout and I was still working. We really didn't shut down at all, which was surprising. But I was wearing all this PPE, but nevertheless, I was always scared. And I had some patients who died from COVID. And I remember being fearful that it was me that caused it. And I got tested and I never got COVID, thankfully. But I remember that fear, that anxiety, it really weighed on me. And it kind of contributed to my burnout and my emotions. But also, yeah, I noticed it with my patients. They're also fearful. I had this one patient. I remember, like, I showed up and she was so scared of me. She was like backing away from me, and she didn't want me to come anymore. It was almost like I was an alien. And
Hmm.
I get where it's coming from. They're just scared, and it was sad to see amongst my patients, and I felt it for sure as a clinician.
Well, because the scene in New York was insane.
Yeah, I mean, yeah, I was right outside New York. I live in northern Jersey, so like right outside of Manhattan. But yeah, it was pretty crazy, and it was scary. A lot of I've had many patients who died from COVID. It was just really sad.
And have you found benefit with a psychologist as well, or do you find that you have enough tools in your toolbox to understand yourself and
Yeah, definitely. Yeah, it's been a long time. I actually went through a trauma myself. I share it with some people, but I had a daughter who passed away many years ago, 10 years ago.
wow.
So yeah, that was really traumatic for me and my wife. So I mean, she was sick, and it was just really hard for us. But yeah, definitely seeing somebody and talking about your emotions was really important. Really critical.
Was there a point where you needed to admit like I need to get help, or was that something that you were like, listen, like this is bad, I need to? Did you like maybe do preliminary stuff because you had already dabbled in it?
No, I mean, I actually thought I could do it myself, which was kind of a mistake. And then at a certain point, it was actually my wife, and she's like, you really need to see somebody. And I was kind of hesitant. I also had biases against it early on, even though I love psychology. For some reason, I had a bias against going to a psychologist. Maybe it was how I was raised. My father's a neurologist,
Mm.
and he's like the opposite of a psychologist. Like, he kind of thinks everything is anatomical. Nothing is about the unconscious and the mind. So I probably had a bias towards it. But yeah, my wife was very helpful in helping me overcome that. And then I realized how beneficial it was for me. And it was just huge. It changed my life. So yeah, it was definitely beneficial. So, but I don't recommend it after going through the experience, even for somebody who hasn't been through a trauma like that. I mean, I definitely recommend it because it's eye-opening.
Yeah, was your father a big motivator for you to work in the healthcare field?
Yeah, he was. He's a very passionate clinician. He loves working. He's 75 years old, and he refuses to give up. He's gonna work. He's gonna work till it's forever. He loves it. It's like his whole life. So I definitely respect that, and I saw that within him, his drive towards patient care, and it was definitely a motivator for me.
That's great. And
Yeah.
you talk about all these intrinsic motivators and using psychology in your own life. And I guess, do you find it easy for you to exercise, and what's your relationship with exercise? I guess I want to know.
Well, good question. It's another area where I need to improve on. I love biking. So that
Mm.
is my intrinsic motivation stems from road cycling because I love
Yeah.
it. The issue for me is time because I have three kids, and also just a time factor. But yeah, I mean, I'm in decent shape. I could definitely do better. I can improve on my eating habits. Right now, like there's a bit of a stress. I'm moving, so there's a bit of a stress with moving. But nevertheless, yeah, I could do better, but I'm okay. Yeah, I love working out and I love biking. So that's
Well,
really
I bring it up because much like how psychology is kind of something that's maybe more new aged in regards to talking about, I feel like talking about exercise and eating habits and things like that is something that's perhaps maybe at a direction that society needs to go about, and talking more openly about kind of like finances. I feel like people don't feel like when you start talking about it, you're like, yeah, I could do better.
right. It's true. It's true.
Yeah, and I think we, as physical therapists, we kind of like dive right into that, like where we have this unique opportunity to like open up and talk to patients immediately about like what do you do exercise wise, like what are you doing, maybe for you for home health, I'm assuming that your patients are pretty low level in regards to activity level,
Yeah.
but for like outpatient, I see patients in their homes, and it's just for like outpatient stuff in their homes. And so
Right.
the first question I asked, or one of the first questions I asked, is like, all right, what's your relationship with exercise, or what else are you doing outside of making sure that your knee doesn't hurt or whatever. So
Right.
I think that's another unique quality that PTs have, is we can kind of stem into the idea of exercise and hopefully bring in some of these traits that you've been talking about.
Definitely. Yeah, definitely.
Well,
Most of my patients are geriatric, so they're not like high level athletes. Most of them, I think the average age is like 80. So that's most, but I do have occasionally, I have younger patients. Like I told you, I had that knee replacement patient who's like in his late 40s. And
right.
yeah, so it's a different clientele, different patient base, but yeah.
What's the oldest patient you've worked with?
I had a patient who's 105.
Wow.
I have a patient right now who's 103.
Jeez.
Yeah, it's pretty crazy. But the best, I had a patient who was 99, but she looked like she was 70. So that was like the patient that I have who's 103. He has like a little bit of dementia, and he just like he's a little out of it. And even the 105-year-old, but this 99-year-old lady, she was like, it was like she was driving. It was like, what? It was incredible. So
Yeah.
yeah, but I've had some pretty old patients. Yeah.
Yeah. I currently have a 99-year-old as well, actually, and doing pretty well as well. Just I don't think they drive anymore, but at the very least, fairly active for their age, and it's great to see.
I love asking them about the past. Like I love asking them what it was
Mm.
like in America during World War II, or I love like learning about that stuff. So there's definitely an advantage. Like I had a patient once, just a quick story. I had a patient once, and I noticed that he had all these pictures of Franklin Roosevelt and Eleanor Roosevelt in his house, like all over. He even had a sculpture of Franklin Roosevelt. And I was like, why do you have, and he had a rather large house, and you could tell that, or it seemed like he was of the wealthy, was wealthy. So I asked him, like, why do you have so many FDR, pictures and stuff? He's like, because I was friends with FDR. I was like, what? He's like, yeah. I said, how did that happen? He said, oh, when FDR was running for president, Eleanor would go to these schools and these colleges and try to raise awareness of her husband. And I was the head or the president of my school's political affiliation party. And we started corresponding, and then I started sending letters to FDR, and he invited me to the White House in 1942, and I was there with Churchill and FDR. I was like, what? I was like, are you serious?
What?
I was
That's
like, that's so cool. I'm
insane.
like, I'm treating a patient who was in the White House in 1942, having a lunch with like Churchill and FDR. It's just cool. I mean, it's amazing.
I mean, to
You have
even
these
be in
like,
the same, to even, I mean, my God, that's
yeah, yeah. So that was pretty cool. And yeah, whenever I have patients, I'm very fascinated with what it was like in America during World War II. So when I have patients, like who are that age, in their 90s now, I'll say, were you scared? What was it like? What was the food shortage situation like? I like learning about this stuff also. So yeah,
and I'm sure it's a great way to connect to the patients, because I'm sure
yeah,
they
and
love
that's
talking about it, right?
exactly, they love talking about it. So yeah, so it's another great way to connect.
Great. Well, listen, we're wrapping up things here. It's been already an hour, I believe it or not. So I kind of want to close out with a couple final questions. And this is the health me to health you closing remarks. And you've had a little bit of time to look at the questions. And so I think one of these you've already asked or answered already. But the first question is, if you had the attention of everyone in the world for 30 seconds, what would it be? Or what would you say?
as a in general, or put things in perspective. But
How,
no, I would I would say that yeah, psychology is a really valuable tool in terms of not just connecting with your patients, but also understanding yourself and really improving and growing as a person. So
Mhm.
don't underestimate the value of psychology. And as we talked about before, definitely seek out somebody else as an objective, or as a psychologist, psychiatrist, or even a friend. Seek somebody out that could help you become more self-aware, and in doing so, you'll be happier, a healthier person.
Absolutely. And we talked about many books. You've talked about many books throughout this podcast and recommendations. And I think if you had a place to start, what would be the first book that you would recommend to somebody who they want to learn more about human psychology?
Yeah, so I would check out Dan Ariely's book, Predictably Irrational. It's an incredible book. It's an easy read. He's a fantastic individual himself. He has a really interesting story. He was in Israel, and he actually he was burnt. Like half his body was burnt by some type of electrical fire, and he had to be he was in the hospital for many years. And he goes through. He's very honest about his himself and his appearance. His appearance looks weird, like he has scars all over his body, and he's a very humble individual. You can tell through his writing, but it's really enjoyable. Just the read it's really easy, and it's really enlightening. So Dan Ariely, Predictably Irrational, is one book that I recommend. I would start with.
All right, write it down, and then you can tackle all the other ones in the podcast. And the last one, where can more people find out about you and your courses? For other therapists, he has a continuing education courses, and then for other people who want to learn more about what he does, where can people find you?
Yeah, so my website is psychologyforthebodiceu.com, but I also own the domains of psychologyforthebody.com or psychologyforthebodyce.com. So if you put in any of those, you'll come to my website. And on my website, you have my background and also my courses that I sell both on demand and live. I do live webinars, and all of my courses are AOTA approved. So occupational therapists can get credits for their license, and also New York Board of PT approved. And some of my courses are approved by New Jersey for live credits. So if you're interested in learning more about psychology and also getting some CUs, check out my website at psychologyforthebodyceu.com.
Perfect. Great. Well, listen, it's been great talking to you, and I'm sure there's so many things that people are going to be able to benefit from listening to this podcast. So thanks for coming on.
Thank you so much. I really appreciate it.